This podcast is aimed at sports massage students. It provides demonstrations of various soft tissue release techniques in the treatment of a kayaker with upper cross syndrome. Soft tissue release techniques shown should act as revision, and the sport-specific example should provide the thought process involved when treating the sport-specific injury. Upper cross syndrome involves a chain reaction during which some muscles become shortened and others lengthened and weakened. Upper cross syndrome involves pectoralis major and minor, upper trapezius, levator scapula, and sternocleidomastoid, all becoming tightened and shortened. Lower and upper middle traps, serratus anterior, and rhomboids all become lengthened and weakened. Visible signs of this syndrome are rounded shoulders, a head forward position, and arms medially rotated. Observations of kayakers show them hunched forward in their boats, producing large arm adduction movements against the resistance of the water. Continual repetition of this activity may lead to muscle imbalances found in upper cross syndrome. Traditionally, latissimus dorsi is not included in upper cross syndrome. However, due to the extensive use of this muscle in kayaking and its insertion onto the bicipital groove of the humerus, it can further compound the problems associated with upper cross syndrome if hypertonic, by further medially rotating the humerus. When testing the extensibility of any muscle, a knowledge of the origin, insertion, and action are vital. Once this information is known, the demonstration shown can be applied to any joint to assess the range of movement permitted by the associated muscles. Pectoralis major originates from the clavicle, sternum, and first to sixth ribs. It inserts onto the lateral lip of the bicipital groove of the humerus. It horizontally adducts, flexes, and inwardly rotates the arm. The example shown tests for extension of the shoulder permitted by pectoralis major. However, the arm could be easily moved into an abducted position to test for the tone of the fibers responsible for adduction. Latissimus dorsi originates from T7 to T12 and via the lumbar fascia to L1 to L5 and the iliac's crest. It inserts onto the bicipital groove of the humerus. It adducts, draws back, and inwardly rotates the arm. Start by lifting the patient's legs to flatten their lumbar spine into the couch. This helps anchor the latissimus dorsi's origins of L1 to L5 and the iliac crest. Next, ask your patient to lightly contract their abdominal muscles. This helps anchor the rib cage where the pectoralis major originates. Take hold of both arms and ensure the patient is relaxed and will allow you to passively move them. Moving the arms into the position shown tests for tone in the pectoralis major. The upper arm should come level with the couch. If not, this indicates increased tone within the pectoralis major. With the arms in this position, the latissimus dorsi can be tested. When the arms are extended above the head, they should remain in this position. If the arms recoil back towards the body, this indicates excessive tone within the latissimus dorsi muscles. Throughout this test, ensure the arms are well supported and you are aware of any current or past shoulder injuries, as the shoulder is being placed in a relatively unstable position. The rest of this podcast will now outline STR techniques on the hypertonic muscles associated with upper cross syndrome. STR is the manipulation of soft tissue through specific application of pressure combined with the mobilization of the associated joints. A variety of active and passive techniques are shown. The list shown outlines the contraindications to STR. In this example, a broad lock is being employed to the pectoralis major, and the arm is being moved passively to apply a stretch to a large area of the muscle. Notice how the practitioner moves the arm to ensure all the fibre directions are stretched. A broad lock should be employed before the use of any specific locks. When working with a female patient, the following technique can be used to place a broad lock on the pectoralis major. Once specific areas of tension have been identified within the muscle, specific locks may be employed. Only relatively small joint mobilizations are needed to provide the stretch. Pectoralis minor originates from the 3rd to 5th ribs and inserts onto the corticoid process of the scapula. It draws the scapula forward and down. Start by sliding your hand underneath the pectoralis major. Aim diagonally upwards towards the 3rd to 5th ribs. Place a lock on the pectoralis minor by pushing your fingers down. Once the lock is in place, ask the patient to draw their shoulder back by activating their rhomboid muscles. This is an example of an active STR technique where the patient is in control of the stretch. To apply STR to the latissimus dorsi, place the patient inside lying. Take hold of their arm and ensure it is well supported. Apply broad locks to the entire length of the muscle. In this example, the patient is being moved passively. However, this could be performed actively, where the practitioner places the lock and the patient extends their own arm above their head. Again, specific locks are employed after the use of broad locks on specific areas of tightness. The closer the lock is to the joint being mobilized, the less movement required to apply the stretch, compared to a lock more distal to the joint. Upper trapezius originates from the occipital to the lateral third of the clavicle. It extends and rotates the neck. Ask the patient to look straight ahead and take hold of the upper trapezius and lightly squeeze it to place a lock. Then ask your patient to rotate their head to place a stretch on the muscle. You may also ask the patient to flex their neck as well to ensure all the muscle fibre directions are stretched. Levitator scapula originates from the transverse processes of C1 to C4 and inserts onto the superior angle of the scapula. It raises the scapula or rotates and side bends the head. First, palpate to find the superior angle of the scapula and place a lock on the muscle using your thumb. You may want to reinforce this lock by placing your other hand over your thumb to apply more pressure or to prevent hypermobilization of your thumb. Ask your patient to flex and rotate their head at the same time to place a stretch on the muscle. Due to the proximity of the sternocleidomastoid to major blood vessels and the respiratory tract, placing an STR lock would prove uncomfortable. Therefore, other techniques should be employed to reduce the tone. Try using muscle energy techniques such as post-isometric relaxation or reciprocal inhibition. In summary, 1. Kayakers may suffer from upper cross syndrome due to the muscle groups used. 2. When testing the range of movement of any joint, a knowledge of the origin, insertion and action are vital. This podcast only outlined the testing of 2 muscles. Try and think what movements are required to test the other muscles outlined in this podcast. 3. Use broad locks before specific locks. 4. A towel was not used in the examples shown, so hand position could be seen. However, STR through a towel provides a greater grip and a better lock in the muscle. 5. Lastly, try incorporating STR into your general massage along with other neuromuscular techniques you have learnt so far on your course.